Urine formation. The kidney converts blood plasma to urine in 4 stages: glomerular filtration, tubular reabsorption, tubular secretion, and water conservation. As we trace fluid through the nephron, we will refer to it by different names that reflect its changing composition. The fluid in the capsular space is called glomerular filtrate. It is similar to blood plasma, except that it has almost no protein. The fluid from the proximal convoluted tubule through the distal convoluted tubule is called tubular fluid. Tubular fluid differs from the glomerular filtrate because of substances removed and added by tubule cells. The fluid is called urine once it enters the collecting duct, since it undergoes little alteration beyond that point, except for a change in water content. The filtration membrane. Glomerular filtration is a process in which water and some solutes in the blood plasma pass from capillaries of the glomerulus into the capsular space of the nephron. To do so, fluid passes through 3 barriers that constitute a filtration membrane: the fenestrated endothelium of the capillary, the basement membrane, and filtration slits. The endothelial cells of the glomerular capillaries are honeycombed with large filtration pores. These are highly permeable, but small enough to exclude blood cells from the filtrate. The basement membrane consists of a proteoglycan gel. The basement membrane excludes molecules larger than 8 nanometers. Even some smaller molecules, however, are held back by the negative charge on the proteoglycans. A podocyte of the glomerular capsule is shaped somewhat like an octopus, with a bulbous cell body and several thick arms. Each arm has numerous extensions called pedicels that wrap around the capillaries and interdigitate with one another. The pedicels have negatively charged filtration slits that are about 30 nanometers wide, creating an additional obstacle to large anions. Almost any molecule smaller than 3 nanometers can pass freely through the filtration membrane into the capsular space. This includes water, electrolytes, glucose, fatty acids, amino acids, nitrogenous wastes, and vitamins. Such solutes have about the same concentration in the glomerular filtrate as they do in the blood plasma. Some solutes of low molecular weight are retained in the bloodstream. However, because they are bound to plasma proteins, they cannot get through the membrane. For example, most calcium, iron, and thyroid hormones in the blood are bound to proteins that retard their filtration by the kidneys. The small fraction that is unbound, however, passes freely through the membrane and appears in urine. Kidney infections and trauma can damage the filtration membrane, allowing albumin or blood cells to filter through. Kidney disease is sometimes marked by the presence of protein or blood in the urine. Distance runners and competitive swimmers often experience temporary proteinuria and hematuria. Strenuous exercise greatly reduces perfusion of the kidneys, and the glomerulus deteriorates under the prolonged hypoxia, thus leaking protein and sometimes blood into the filtrate. Filtration pressure. Glomerular filtration follows the same principles that govern filtration in other blood capillaries, but there are significant differences in the magnitude of the forces involved. The blood hydrostatic pressure, or BHP, is much higher here in other capillaries. This results from the fact that the afferent arteriole is substantially larger than the efferent arteriole, giving the glomerulus a large inlet and a small outlet. The hydrostatic pressure in the capsular space is about 18 millimeters of mercury, compared with a slightly negative interstitial pressure that exists elsewhere. This results from the high rate of filtration and continual accumulation of fluid in the capsule. The colloid osmotic pressure, or COP, of the blood is about the same here as anywhere else, and is 32 millimeters of mercury. The glomerular filtrate is almost protein-free and has no significant colloid osmotic pressure. However, this can change markedly in kidney diseases that allow protein to filter into the capsular space. On balance, then, we have a high outward pressure of 60 millimeters of mercury, opposed by 2 inward pressures of 18 and 32 millimeters of mercury. This gives us a net filtration pressure, or NFP, of 10 millimeters of mercury in the outward direction. In most blood capillaries, the BHP drops low enough at the venous end that osmosis overrides filtration and the capillaries reabsorb fluid. Although BHP also drops along the course of the glomerular capillaries, it remains high enough that these capillaries are engaged solely in filtration. They absorb little or no fluid. The high blood pressure in the glomeruli makes the kidneys especially vulnerable to hypertension or high blood pressure. This can have devastating effects on renal function. Hypertension ruptures glomerular capillaries and leads to scarring of the kidneys, or a condition called nephrosclerosis. It promotes atherosclerosis of the renal blood vessels, just as it does anywhere else in the body, and thus diminishes renal blood supply. Over time, hypertension often leads to renal failure, and renal failure leads to worsening hypertension in an insidious positive feedback loop. Glomerular filtration rate. The glomerular filtration rate, or GFR, is the amount of filtrate formed per minute by the two kidneys combined. For every 1 millimeter of mercury of net filtration pressure, the kidneys of a young adult male produce about 12.5 milliliters of filtrate per minute. This value, called the filtration coefficient, depends on the permeability and surface area of the filtration barrier. The filtration coefficient is about 10% lower in women than in men. For males, the glomerular filtration rate equals net filtration rate times the filtration coefficient, or 10 millimeters of mercury times 12.5 millimeters of mercury, equaling 125 milliliters per minute. In young adult females, the glomerular filtration rate is about 105 milliliters per minute. These rates are equivalent to 180 liters per day in males and 150 liters per day in females. These are impressive numbers, considering that it is about 60 times the amount of blood in the body and 50 to 60 times the amount of filtrate produced by all other capillaries combined. Only a small portion of this is eliminated as urine. An average adult resorbs about 99% of the filtrate and excretes 1 to 2 liters of urine per day. Regulation of glomerular filtration. The glomerular filtration rate, or GFR, must be precisely controlled. If it's too high, fluid flows through the renal tubules too rapidly for them to reabsorb the usual amount of water and solutes. Urine output rises and creates a threat of dehydration and electrolyte depletion. If the glomerular filtration rate is too low, fluid flows sluggishly through the tubules. They reabsorb wastes that should be eliminated in the urine, and a condition known as azotemia may occur. The only way to adjust this glomerular filtration rate from moment to moment is to change the glomerular blood pressure. This is achieved by 3 homeostatic mechanisms: renal autoregulation, sympathetic control, and hormonal control. Renal autoregulation. Renal autoregulation is the ability of the nephrons to adjust their own blood flow and glomerular filtration rate without external control. It enables them to maintain a relatively stable glomerular filtration rate, in spite of changes in arterial blood pressure. If the mean arterial pressure rose from 100 to 125 millimeters of mercury and there were no renal autoregulation, urine output would increase from the normal 1 to 2 liters per day to more than 45 liters per day. But because of renal autoregulation, urine output increases only a few percent, even if the mean arterial pressure rises as high as 160 millimeters of mercury. Renal autoregulation helps to ensure stable fluid and electrolyte balance, in spite of the many circumstances that substantially alter one's blood pressure. There are 2 mechanisms of autoregulation: the myogenic mechanism and tubuloglomerular feedback. The myogenic mechanism of renal autoregulation. This mechanism of stabilizing the glomerular filtration rate is based on the tendency of smooth muscle to contract when stretched. When arterial blood pressure rises, it stretches the afferent arteriole. The arteriole constricts and prevents blood flow into the glomerulus from changing very much. Conversely, when blood pressure falls, the afferent arteriole relaxes and allows blood to flow more easily into the glomerulus. Either way, glomerular blood flow and filtration remain fairly stable. The tubuloglomerular feedback of renal autoregulation. This is a mechanism by which the glomerulus receives feedback on the status of the downstream tubular fluid and adjusts filtration to regulate its composition, stabilize nephron performance, and compensate for fluctuations in blood pressure. It involves a structure called the juxtaglomerular apparatus. The juxtaglomerular apparatus is found at the very end of the nephron loop, where it has just re-entered the renal cortex. Here, this loop contacts the afferent and efferent arterioles at the vascular pole of the renal corpuscle. Tubuloglomerular feedback begins with the macula densa, which is a patch of slender, closely spaced sensory cells on one side of the loop. When the glomerular filtration rate is very high, the sodium chloride level in the nephron loop is also sharply elevated. Cells of the macula densa absorb sodium, potassium, and chloride ions, and water flows osmotically. The cells swell and secrete ATP from their basal surfaces. The ATP is metabolized to adenosine by nearby mesangial cells. Adenosine acts as a paracrine messenger that stimulates the nearby juxtaglomerular cells, or simply granular cells. These are modified smooth muscle cells wrapped around the afferent arteriole and, to a lesser extent, the efferent arteriole. They respond to a rising adenosine level by constricting the afferent arteriole. This reduces blood flow into the glomerulus, thereby reducing the glomerular filtration rate and completing a negative feedback loop. The mesangial cells of the glomerulus may also contract, constricting the glomerular capillaries and reducing filtration. Mesangial cells also form a supportive matrix for the glomerulus and phagocytize tissue debris, preventing the glomerular filtration membrane from clogging up. Just beyond the juxtaglomerular apparatus, the distal convoluted tubule has a limited capacity for sodium chloride reabsorption. The tubuloglomerular feedback process may help to prevent overloading the distal convoluted tubule with sodium chloride, and thus prevents excessive salt loss and water loss in the urine. Granular cells are named for the fact that they contain granules of renin. Renin is secreted from the granular cells in response to a drop in blood pressure. This initiates a Renin-Angiotensin Aldosterone mechanism, which restores blood pressure and supports blood volume. Two important points must be noted about renal autoregulation. First, it doesn't completely prevent changes in the glomerular filtration rate. Like any other homeostatic mechanism, it maintains a dynamic equilibrium. The glomerular filtration rate fluctuates within narrow limits. Changes in blood pressure do affect the glomerular filtration rate and urine output. Second, renal autoregulation cannot compensate for extreme blood pressure variations. The mean arterial pressure, or MAP, range of 90 to 100 millimeters of mercury, the glomerular filtration rate remains quite stable. Below 70 millimeters of mercury, however, the glomerular filtration and urine output cease. This can happen in what's called hypovolemic shock. Sympathetic nerve fibers richly innervate the renal blood vessels. In strenuous exercise or acute conditions such as circulatory shock, sympathetic stimulation, and adrenal epinephrine constrict the afferent arterioles. This reduces the glomerular filtration rate and urine output while redirecting blood from the kidneys to the heart, brain, and skeletal muscles, where it is more urgently needed. Under such conditions, the glomerular filtration rate may be as low as a few milliliters per minute. The Renin-Angiotensin Aldosterone mechanism. Any substantial drop in blood pressure due to bleeding, dehydration, or other cause is detected by the baroreceptors in the aorta and carotid arteries. They transmit a signal to the brainstem, leading to various corrective sympathetic reflexes. One such response is that sympathetic fibers stimulate the granular cells to secrete the enzyme renin. Renin acts on Angiotensinogen, which is a protein in the blood plasma, to split off a 10 amino acid peptide called angiotensin 1. In the lungs and kidneys, angiotensin converting enzyme, or ACE, removes 2 more amino acids, converting it to angiotensin 2. Angiotensin 2 is a hormone that acts in several ways to restore fluid volume and blood pressure. Angiotensin 2 is a potent vasoconstrictor. Widespread vasoconstriction raises the mean arterial blood pressure throughout the body. In the kidneys, angiotensin 2 constricts the efferent arterioles and, to a somewhat lesser degree, the afferent arterioles. By constricting the glomerular outlet more than the inlet, it raises the glomerular blood pressure and glomerular filtration rate, or at least prevents a drastic reduction in the glomerular filtration rate, thus ensuring continued filtration of wastes from the blood even when the blood pressure falls. Constriction of the efferent arteriole lowers the blood pressure in the peritubular capillaries downstream. Since capillary blood pressure normally opposes fluid reabsorption, this reduction in blood pressure strongly enhances the reabsorption of sodium chloride and water from the nephron. More water is then returned to the bloodstream instead of being lost in urine. Angiotensin 2 stimulates the adrenal cortex to secrete aldosterone. Aldosterone promotes sodium and water reabsorption by the distal convoluted tubule and collecting duct. Angiotensin 2 also directly stimulates sodium and water reabsorption in the proximal convoluted tubule. It stimulates the posterior pituitary gland to secrete antidiuretic hormone, which promotes water reabsorption by the collecting duct. Angiotensin 2 stimulates a sense of thirst and encourages water intake. The renin-angiotensin-aldosterone mechanism collectively raise the blood pressure by reducing water loss, encouraging water intake, and constricting blood vessels. Thank you for watching.